Well, hello, everybody. I'm glad
Hi,
that
Ryan.
you all are, I think, familiar faces. So that makes me feel slightly better. Um, I'm glad to be here tonight. Rachel asked me a month or so ago to present on something, and I could probably present on a lot of things, but it's easiest for me to present on stuff I'm reading about and I'm actually interested in, and I don't know about as much, so that I have an opportunity to learn about it. So that's what got me here today. I wanted to set this up mainly today as an open discussion, like it says in the title. This is a subject that I've been working on for probably the last 3 years, but really pretty hard over the last 18 months. And it becomes a complex topic in the rehab recovery world to talk about psychedelic assisted therapy. And I recognize that. And to be fair, in that situation, like I haven't talked about it much for fear of judgment or reprisal. But I never got anywhere in my life fearing judgment or reprisal too much. So I just decided that I would gonna throw that where it usually needs to go and go ahead with it and start to just engage other professionals in their thoughts because like I said, I've been doing a lot of studying, a lot of interacting with this particular topic in with the literature and with my professional life, but not a lot with other people. And I recognize that most of the good thing that have happened to me, you know, outside of avoiding, judgment is through collaboration through colleagues. And I'm sure people have had experiences or information or something like that I don't know about. And some of that's given my own silo of study here. And some of that is given the fact that, this is a very new topic. Um, so I'll dive into it, but please, I guess with that introduction, it's best, I think, especially since we're a small group, which is great, um, to embrace the discussion format and please like ask me questions as they come up. We're not gonna, focus too much on the saving, time at the end. I'd rather just have you ask questions in the middle and have other people chime in whatever they know about or whatever their experience is. So that said, I think most of you know me here on this call. I'm an LCSW by training, and I've been in the treatment world, at least as a professional, since 2001. Prior to that, as a patient, um, and ran another local clinical or program, dual diagnosis program here in Salt Lake City from 2002 until 2008. I was their clinical director, and then in 2008, I founded Ascend, and that's a dual diagnosis residential program here in Salt Lake that has really three phases of care. We have residential, transitional, and sober living. And our average patient is with us about 6 months through that continuum of care. I've recently transitioned over. This has just been over a year to out of the CEO role, and so I'm technically at this point had the wonderful opportunity of firing myself, which is a lot easier than being fired by somebody else. Um, and I'm currently in the role of clinical director at the sober living program, and it's been a wonderful change for me to do more clinical work than I was doing in the CEO job. So this topic, psychedelic assisted therapy, I'm sure you've been reading about more and more. It's becoming more and more prominent um, in journal articles that are in our field as well as in mainstream press. And as it started to dribble out, um, it started kind of pushing into me more and more, and got to the point after reading one article. I'd read one article, and then I was reading an article about just kind of randomly about this guy named Desmond Ford. And in the article, he said he was a Seventh Day Adventist kind of person who left that religion and he was a Christian theologian. And anyway, in the article right after I was thinking about how I didn't really need to change my mind about psychedelics was this quote where he said, "To change your mind is the best evidence that you have one." So took that as potentially a guiding opportunity for myself, and just decided to open up my brain. I've in my career, I mean, I've been doing this for 22 years now, and why don't you go to the next slide if you could, Chelsea? Um, in my career, and I'm sure many of you are the same. I think I'd like to say that I think in terms of research articles and data, but I probably most often think in terms of people. And as I'm uh, thinking about what I can do to make our practice better and how I might need to push and pull myself to run down all avenues to work with the chronic diseases we do, I often think of these two patients, and these two patients represent Lisa and Ashley. I think of others, but these ones are pretty constant. And Lisa and Ashley were good examples of people who had been to treatment a couple times, who had really just seemingly unreachable mental health, trauma issues, depression issues that would seem like we could get a certain distance and they were just kind of turning the corner. And then it would seem like kind of out of nowhere, whatever the issue was, well, there was always the same issue, the PTSD depression combo would pull them back in and just become more and more intractable despite having them in treatment with me multiple times and before me in treatment with lots of other programs. And I think what's true of both of them is I think there's a set of patients in my life who lost their battle with this disease that didn't give it much of an effort. Not blaming them for that. I'm just saying that would be my assessment. And some of those were random. And some of them, the more tragic situations, are people I know that it gave it everything they had. And I know they worked as hard as they could. They followed as much as they could in the direction, and the disease just got them. And so in this, wait, I got to move this. Oh wait, no. In this slide, I looked through my journal and just to kind of give you a flavor of these types of situations. And as I talk about it, I'm sure as I've even given this kind of preamble, you've thought of patients that represent this to yourself. But Lisa was a patient I had in 2003, and as I went to her funeral, I wrote the following quote in my journal. It says, as I looked at her gray swollen body, I could see her parents observing me in the casket. I was in between Lisa's shell and her parents as they sat heads down, weeping for their daughter and themselves. They were mourning in a sense that meets the full measure of that word. I was stuck, both literally and figuratively. I was cemented between the dead and the lost. I felt helpless. And that was really my first experience with losing someone who I know worked really hard to get sober and recover. And I guess that one just stays with you. And I've always, from really that day forward, realized that not what I'm not trying to do is, help people get back into college or help them get their wife back or help them get their boyfriend back or help their family talk to them again. I know that's what they think I'm trying to help them do, but what I'm trying to do is literally save their life. And then I had another really amazing experience with Ashley. She passed away in 2016. And I went to her funeral, as I try and do every time, even though that's my least favorite part of the job. And as I was at her funeral, I was kind of dreading going. That parents had this line of welcomers that they had everyone kind of parading through in this kind of funeral. And I was dreading doing that, but didn't want to be the one sulking in the back, not being willing to have the courage to talk to these people. The mom was probably not the most stable mom I've ever had. And so I was pretty much imagining that she was going to go off on me in the line of the funeral. Um, but she didn't. She said the following thing to me. She said, "Thank you, Ryan, because of you and your team at Ascend. We had some wonderful years with Ashley that we would never have had if she had not been helped by Ascend." And I'm so grateful for her that she said that, because even outside of, I think for so long I'd spent, in the recognition that this was a life or death issue, but also worried that that's all it was. And that what that experience with Ashley taught me is that even if we do lose patients, as tragic as that is, and as kind of technically treatment failure as that is, it's actually not a treatment failure if they had years that they would have had with family and in their own lives and with their own loved ones, that are valuable, that are better than using. And so it's with the kind of idea of these two patients that I started, recognizing that, at the end of the day, then hopefully the next thing is out there that would have made a difference in these two patients, because the next Lisa and Ashley for me are tomorrow. They're right around the corner. And by pushing myself in my own practice and my own development is certainly the only way I get there. Now, in talking about that, I don't think that, and I think this will be common. I think that, we'll be flooded by the fact that psychedelics are the panacea of treatment at this point, because we get as addicted to the next miracle as anyone else does. And I don't think that's that, but I do think that there's a percentage of people that could be helped here, and that's who I want to talk about. And for me, those people are Lisa and Ashley. I want to show the next. Go ahead and click the next slide. So where we're at now with our tools with regard to PTSD and depression, those are the two, anxiety as well, but those are the two, and to some minor degree, the data isn't really good on substance abusers, but the two major, I think, areas of studies have been intractable depression and PTSD with regard to psychedelic treatment. I really am kind of most supportive of an organization called MAPS. If you want to look them up, they have done, it's like the most multidisciplinary association of psychedelic science is the way the acronym breaks down. And I think they're doing the most legitimate research, them and as well as the Department of Veterans Affairs. MAPS and the person that runs that have been trying to legalize specifically MDMA therapy for PTSD treatment since 1984. They're currently in just, I think, at the very tail end of phase 3 trials. Like, I was at their conference in July, and they are pretty confident that this will become legalized in 2024. And so I'm going to show you a slide with regard to their most recent study that's part of their phase 3 phase 3 trials. But this is the first half of that slide that shows what really our results are now. The chart is going to show results with people who are measured on a CAP test to measure. When the CAP test is a measure with regard to the reduction of PTSD symptoms and PTSD improvement. It's been used for years. It's a validated measure. And what we know is that what we have now, which is, the various modes of therapy, but therapy in general, as well as medication, have a massive impact. They take things from about, roughly 20-25% results to about 50% results. And they also have a compounding impact that over time, over the number of sessions, those things increase. And so we're looking at results here for in the charts I'm going to show you for only the first three um, sessions. I would estimate, based on what I know about treating these people, that these numbers would go up and down, like maybe down sometime around 6 sessions and back up around 12 sessions. But I think, the initial data and the initial concept is what's valid here. So that's the good news, is that, I don't think we're doing anything that's not working. And I think we're doing most of what we know is effective. The bad news um, uh, is that, only there was only a 50% reduction. There's still 50% of people um, that fall into the unchanged chains, and that's all of our Lisas and Ashleys. So I think what I've always tried to do is try and find how we can increase that. Can you go to the next slide there, Chelsea? Thank you. So this placebo with therapy, which is non hallucinogenic medication and therapy, and this is about where people are at. You can see the actual dark blue there is full remission patients, and the next shade of blue, lighter, is a full loss of diagnosis. And then after that you have people that had some response, and then that big gray area is no response at all, and then the white area is withdrawers. People withdrew from therapy, and you can see the other problem is that wide area gets bigger as people go to sessions and feel like it's not making a quick enough, big enough impact on them. So at the end of last year, Nature magazine, which is a very well-respected journal, published the MAPS organization's phase 3 trials results for specifically MDMA therapy. And that's the next slide. So we'll look at where we're at now in comparison to their results. So you can see that the big impact for me is that you take that area that Lisa and Ashley are at, and you start to put them in the impacted range of treatment. We were talking about a loss of diagnosis, the complete remission lines are massive, which I think is undeniable, as well as there's a reduction in, if you compare them to the blue lines, in that gray area, which is just the zero response. And there's also, more importantly, a reduction, I think, in the withdrawal area, the withdrawal patients. And I think that can be attributed there at that top end of the scale with the white box, down to what people are starting to experience at the bottom level, and in that they're more quickly starting to experience relief from their symptoms. Any thoughts on that? Questions on that? Rebuttals to that? All right, we'll go to the next slide. There's a couple of summaries of this type of research. They had a sample size of 90 people. I'd point your eyes down to the middle of the first paragraph, where it says 2 months after treatment, 67% of the participants in the MDMA group no longer qualified for a diagnosis of PTSD. I wonder what we would think if we had, objective, verified research that told us that there was a 67% chance of removing the symptoms of PTSD, and we just didn't know it was psychedelics. I wonder what we'd think then. Compared to with a 32% in the placebo group. So I think in some ways the results are so profound that they're just very compelling. If you go to the next slide, it kind of gives some of the data more in breakout. Thanks, Chelsea. Oh, there you go. Okay. I think the important sentence here is if you look at where it's down about 4 lines where it says previous comparison of the change in CAP score against, again, that's the PTSD validation measure between sertraline and placebo. Shoot, what's sertraline is freak. That's which generic is that? I think that's it's an SSRI. Um, it's an SSRI. I forget which SSRI, but showed
Zoloft.
what's that?
Zoloft.
Okay, Zoloft, yeah. And placebo showed an effective size of 31%. Similarly, um, the CAP score between the prazoxetine is Prozac showed an effective size of 56. By contrast, the effect size of 0.91 was demonstrated in the study between MDMA assisted therapy and placebo with therapy, larger than for any other previously identified PTSD psychopharmacology. I think one thing you can kind of glean as you look at these studies is that in many ways psychedelics are um, interesting because they don't as much operate with dopamine as the other drugs. They're really a serotonin increasing mechanism, which ironically, for all our potentially previous categorization of psychedelics, is similar to the same um, judgment we levied against antidepressants and as people in recovery when they first came out, since they're also serotonin impacting agents. And so, um, we I think it's no accident that we're working with really the same chemical in the brain. The other piece that's really important, as if I pause here, this study was done at Johns Hopkins in conjunction with the MAP piece to kind of further legitimize it. But the other piece that I think is important when you're starting to look at this research, and I think this will be common as this comes out in the community, is that this when they're using I think people are going to start saying psychedelic therapy, which is not what we're talking about. Specifically, the protocols in this study combined psychedelics at usages that can be tolerated for talk therapy, and not put someone in such a state um, of impact from the drug that they're not really able to carry on a therapeutic session. They've specifically have a set protocol that's linked to these studies, which is 6 sessions long. It's also the protocol that the current ketamine usage is being used at as a slightly different form of this type of therapy. And so I really want to point that out that I think that's really important because I think that's going to be as people get more and more googly eyed about just taking MDMA and being totally sober the rest of their life. That's not what we're talking about here. That all of the data that we do have on this topic is definitely linked to the medication as being an assisted part of the therapy and not sufficient as a medication unto itself. So a couple of conclusions, at least that I've drawn from my own slide or from my own kind of work with this. If you can hit the next slide there. Oh no, we're supposed to talk about contraindications first. All right, so contraindications, patients that can't really take or follow this line of therapy. One is patients on any SSRIs or MAO inhibitors for depression or PTSD already. Because these particular psychedelics work to release additional serotonin in the brain, if someone's on an additional SSRI that is having an impact on their serotonin at a biological level, that's going to flood the brain with too much serotonin, and that can be a life-threatening condition. It's called serotonin syndrome. So patients need to be medically monitored and removed off their existing antidepressants, at least for some period of time, to engage in the treatment. Two, any patients with a history of high blood pressure or uncontrolled heart disease or vascular disease, psychedelic treatment due to the biological effects on the brain does have a relatively common side effect of increasing your heart rate and your blood pressure for the couple of hours when you're under the impact of the psychedelic. And so those patients would need to have, as well as seizure disorder patients, would have to have some sort of a cleared evaluation from a cardiologist before they can do that. I'm quite sure at this point cardiologists don't understand enough about this to what they're willing to clear and what they're not. But in at least for the present moment, those patients are contraindications. And then patients with a family history of psychosis. As we all know, these medications are not without their fallout and impact, and they're not to be toyed with. If the drug, there needs to be, if there is any sort of issues around psychosis that's drug induced, that wouldn't necessarily contraindicate someone if they don't have a family history, but appropriate time should be spaced out between the complete absence of having any drug induced psychosis and any psychedelic treatment. Generally, people are talking about being at a minimum of 6 months, and probably more recommended at a year, that they would be free of any drug-induced psychosis. Next slide on contraindications. Patients with recent, oh, that's too far. The one up there, up that. Patients with recent or unaddressed trauma. I think this is very important. I think it's very key. I think I worry that as these medications become more validated and really accepted, that people are just going to, come in with recent trauma. They're going to get diagnosed with PTSD, and people are going to throw them right into these sorts of treatments, which would be a significant mistake. As it says in the UCSF study guidelines, they're doing a study right now, and this is their study guidelines. It says people with significant trauma histories who have not yet learned fundamental coping skills or developed a safety plan, example, a stabilization phase of trauma treatment, should not take psychedelics for the same reason they should not engage in therapies like cognitive reprocessing therapy or prolonged exposure. Psychedelics can lead to reliving traumatic experiences and open up repressed traumatic memories that can lead to significant emotional upheaval. So the nice thing about this piece with the unaddressed trauma is that it specifically helps us weed out some potential people that don't have the purest of intentions, or, for lack of a better term, kind of drug seeking type of patients, because specifically, you need to wade through a significant amount of therapy. Again, they recommend 6 to 12 months, where you can have some amount of coping with regard to your trauma before this would be something that would be potentially indicated. All right, next slide. Then the other massive contraindication, as we all well know, is drug addicted people. There, like I said, it is some evidence going on to look at the potential benefits of specifically using psychedelics to treat addiction. At this point, we don't really know anything validated with regard to that. We know what's validated with regard to comorbid diagnoses of PTSD and depression, and how that might impact the relapse rate. We know that, with PTSD, they're more likely to impact, if that doesn't get treated, they're more likely to impact to relapse to substance abuse. But we don't have any specific data with regard to the impact on addicted people in really validated, legitimized studies. I think that this is a big issue facing our industry, is that I think that there should be two different tracks. And if you look at the legalization of psychedelics, as has been, um, started to be validated, you can look at Oregon and Colorado and their legalization efforts, and as really the two different tracks that exist. Oregon's licensed psychedelic usage for therapy, and they require no licensing whatsoever. It's what I call the shaman track. And I think that, for a certain amount of non-addicted people, the shaman track might be just fine. I mean, I know I'm not that person, but I don't, you know, presuppose to judge somebody else that's on that track if they, as long as they follow some real contraindication advice. That being said, I think what'll be lost in what Colorado is doing is only licensing specific centers as centers that can prescribe psychedelic assisted therapy, and and so they're not really licensing the shamanistic track. They're licensing some possession of personal usage in, or they're allowing some possession of personal usage in Colorado, but they're not like licensing the programmatic implementation outside of programs, which I think is a better way of handling it, because I think that what's really going to happen is that there's going to be, um, like I was mentioning before, I think the assisted part of psychedelic assisted is going to be lost, and lost in kind of the general public, um, and it's not going to be seen as assisted, but rather just psychedelic therapy. And so I think that addicts must really be aware of this, that if they're treating, you know, their PTSD or depression, and they have a comorbid diagnosis with addiction, that they addicts need to really make sure they stay on the clinical track and with clinical supervised efforts that have the medically validated um, 6 session protocol. And I worry much of the time, knowing that their prefrontal cortex, God bless them, is so broken that they won't have that. And so I think it's going to take more and more legitimate professionals educating the public at the difference between kind of the shamanistic track and the clinical track. The second piece around the contraindications of drug addicted people is that they must, in the judgment of the therapeutic team, not be med seeking. They must have an intractable mental health and have previous failures, not previously listed as contraindications. Obviously, this comes down to a savvy clinical assessment of the treating clinician and his or her team. Um, I will tell you that as this has been more and more utilized, Ascend has contracted with a physician that is actually our psychiatrist, who went and got trained in specifically the protocols around ketamine assisted therapy. And we've been doing that we've done it in some very limited clinically specific situations for the reason that we assessed as clinically necessary. We've done it 10 times in 2 years, and we treat about 100 people a year. So we're talking about less than 10% of patients met at least our standard for, a contraindication that would, or a clinical legitimacy in needing this type of treatment that would, supersede the addicted piece. So I do think that that's also another area of grave concern for me. I think that you'll have um, plenty of treatment providers, hook people up to ketamine drips or give them MDMA pills, that don't, do much of the assessment around contraindications. They don't do much of the assessment around specifically the contraindication of addicted people. And I think, the downside of the potential benefits of this medication is, I think there's no doubt that through failure of our own systems and people in those systems, it will make some people worse. There's no doubt about that. And I struggle with that because I think that it can make some people better if they can, um, pass the contraindications bars, and if they specifically can kind of pass the bars with us. All of our patients that we've done it with have been either in, well, 9 of them were in our sober living level of care or afterwards. I don't have the breakdown at how many of them after. I'd say like half were in like maybe the latter half of sober living. The other 4.5 were in our, we keep track with our patients in our aftercare program for at least a couple of years, and some of them were, and at least 4.5 of them were in that group of our patients. And then one of them, it was, while she was in residential, that had some specific caveats that we felt necessitated that, and we built some specific caveats around that to kind of protect the rest of the population in that situation. Um, I have to say that I could summarize our results. I have some quotes from people that have been in ketamine assisted therapy under their course of care with us at Ascend. Um, I that I can that are in later slides, but I can summarize it in our results to neutral to great. We have had no bad results. We have had no results where it caused any sort of a relapse. We've had no results that made a patient worse from a diagnostic or a psychotic symptomatology. I'm not saying, again, I don't think this is panacea. I'm very cautious about it. We stick very rigidly to the therapeutic protocols prescribed in the research and in the succession protocol. And like I said, we have a pretty high bar with regard to the patients that we'd be willing to do it with. That said, I mean, there's patients in that 10 group sample size that we have, as small as it is, that I'm confident, very well could have been my next Ashley or Lisa. And I've been amazed at how how much improved they've been. They'd say a lot of the same thing as I've interviewed them, and I'd summarize it through my own experience like this. I think it offers a neuroplasticity of the brain that can help dissolve the ego in some ways, that can help a patient remove some of their experience around shame and increase some of their experience around spirituality in a way that I think would take a couple of solid years of up and down banging of therapy to have some of those moments of breakthrough. And so I don't think it can produce something that therapy can't produce. I think it can produce something quicker, is the way I would summarize it. And the importance about quicker is not only kind of cost and time and treatment, but it's really cost and time of what people do to themselves, in the meantime between when they're starting to re-experiencing their trauma from being sober and when they relapse next. Shortening that window of allowing them some more temporary and beneficial relief, I think is what really can change the situation for drug addicted patients. Next slide, if you could, Chelsea. Maya is one of our patients who we use ketamine assisted therapy with, and this is what she said about it. She said the use of ketamine treatment tremendously helped me process trauma and has been the most powerful experience during treatment. I was able to heal from trauma within and make connections from my own brain. These connections I haven't been able to make until the use of ketamine. I experienced an overwhelming sense of relief, self-love, and kindness through the experience and my therapy around it. I realized that that I am enough, and I can show myself the love that I feel lucky to have been able to arrive at. Maya had been to treatment with us 2 times before. She was a methamphetamine addict. We had to wait. She's a good example of someone who had to wait quite a while to have some of the effects of drug-induced psychosis wear off to be able to do it. And I know Maya's an adopted case, and between the trauma she'd experienced around the adoption, I think she was just so much in kind of fight or flight around attachment issues that it was just, as she did therapy, and like I said, I'd done therapy with her to send twice. She was my patient. It was just difficult for her to sustain, real work around therapy, given the fight and flight response that she was constantly activated by the therapy itself. And I felt that some of the reduction of that through the ketamine and the reformulating of some of the meaning of that while she was being administered the ketamine gave her it kind of let her know what we've been talking about. It was like it's the coolest thing where like you can it's like some of these patients, they come out and they haven't been able to really make the connection between what you're talking about in the therapy and what you're talking about as far as inner child work and mood regulation and things like that. And they somehow can finally get a sense. It's like they can crawl and look at it 100 degrees in the other way and get a sense on what you've been talking about, and from there be able to utilize it better. Next slide after that. Liam H is a good example of really more of an intractable depression case. Um, I mean, certainly PTSD too, but been depressed for some time. His father committed suicide. He had been suicidal around his depression. And his quote on his evaluation was, ketamine along with therapy has helped lift the consistent dark cloud and help me find the person I am, someone I can care for, and push me in a direction to keep growing. This quote kind of happened just out of his own mouth on the third session. And if you had this kind of your standard Eeyore type of patient, the fact that this came from him was really amazing. Let's go to the next slide. I don't know if you've all seen it. There's a author, Michael Pollan, who's an investigative journalist, writes a lot in the healthcare area. He wrote a book called How to Change Your Brain. That's kind of a summary of kind of the history of psychedelic assisted therapy, as well as what's going on now. There's of course a Netflix special if you're lazy, but I think the book is the Netflix special does about the same thing the book does as far as describing some of the results and impact on individual patients. What the Netflix special doesn't do is talk a lot about the history of um, psychedelic treatment, and that a lot of this work was being done in the late 60s and early 70s by very legitimate scientific studies around psilocybin and LSD for both alcohol treatment as well as intractable depression and anxiety back, like I said, in the 60s and 70s. And somehow, as things do, you know, these drugs got co-opted by kind of the hippie movement of the time. And at the same time, you have, Mr. Nixon trying to respond to the silent majority and come up with the war on drugs. Um, and somehow these studies that were far along, that have been going on for over a decade with increasingly good results, were killed off essentially because of kind of the Timothy Leary crowd and the fact that these medications got thrown into the drug abuse. And just like any medications, certainly they can be abused and used for ill-gotten gain. But these studies were really showing good results even by then, and these studies were shut down midstream. In 1972 with the passage of the war on drugs. And they just kind of stopped, and kind of overnight these drugs became were thrown right into the other war on drugs and the research on them stopped. And that part of the book I think is particularly beneficial. I think especially for, someone born after 1972, and who lived in, all the way through the kind of 80s and 90s war on drugs, that the change, that impact of the history and how I'd previously seen these things as drugs, and I switched my brain around to medications, um, really, I think was a valuable part of the book. I've just put a couple of quotes in here that he hits, with regard to these issues. He says, "When the ego dissolves, so does the bounded conception not only of our own self, but our own self-interest. What emerges in its place is an invariably broader, more open-hearted, altruistic, that is, more spiritual idea of what matters in life. One in which a new sense of connection or love, however defined, seems to figure prominently." I think it's easy to read a quote like that and look at it and pass it off as kind of hippie mumbo jumbo about psychedelics, but if you really took psychedelics out of it and you were reading about a form of therapy that was his description of, I think you'd pay attention to it. Next slide, Chelsea. Another part of what he says, which I found really kind of in summary valuable, was psychedelic therapy creates an interval of, and this is kind of a saying about my own description. I think this is a good description of what I've experienced in watching at least the ketamine work that I've done with these patients. Psychedelic therapy creates an interval of maximum plasticity in which the proper guidance, new patterns of thought and behavior can be learned. And I think that that's exactly what it's getting to, and why it speeds it up is it works in a medicinal, research-based way with our neuroplasticity. And we've all been talking for years about the key to neuroplasticity in therapy, and how important that is. And I think psychedelics are one particular vehicle that is going to help us with that. That said, I hope I haven't shied away from being acknowledging of the dangers. I'm certainly not someone who is going to change Ascend into a psychedelic only treatment center. We're still going to do most of what we do, but I'm going to be open to stuff that can help people like Lisa and Ashley and Maya and Liam, and I believe that if we really consider ourselves savvy clinicians, we can tell the difference between the people who need this and the people that don't. And like I said, 9 out of 10 won't, but 1 out of 10 might. And I wouldn't want to miss that situation for their own life or the life of their families, because I've seen too many people that might have been helped by this. I think, regardless or not, the reason why I'm trying to look at what we're going to do here with Ascend is I think that, the day is basically here already, but it's for sure here next year when MDMA becomes legalized, that we'll have to contend with this in some way. I think it's the same thing that, treatment centers back in the mid 80s had to contend with Prozac in this way, and whether that still made someone sober or not sober. Um, and I invite everyone to contend with it in their own way. I just think the option to not contend with it or not think about it, given some of the data that's out there that's legitimate, is probably, in my view, short-sighted. That there's enough good data that I think it bears consideration, and possibly rethinking about what has traditionally been an issue for us that falls clearly into the substance abuse category. So those are my thoughts. You haven't asked me any questions all the way through, so you better ask me some questions now. Thoughts?
Ryan.
Thank you, Ryan.
I want to say, wow, thank you, Ryan. Joyce. Really appreciate this.
Yeah.
Yeah, I wanted to add something too, Ryan. Thank you. I love the way you presented it, because that's why would we want to not pay attention to something that could save lives? So I love the way that you started with why, because I know that I thought it was, I love this concept, so I've been following it for a long time. I actually sat with some people on a plane that were going to Denver, for the
For the
conference, and it was
conference.
really interesting because I sat, yeah,
Oh,
I
I
sat
was
next
at
to an
the
author.
I
I
was
got
at the
so
conference. But as an aside, I'd really recommend that next year. It's there were 13,000 people there, which tells you about the national interest in this. About half of them were professionals like myself in a pair of Dockers and a button-down shirt, and the other half of the people were like on their way to Burning Man. So it's a very eclectic conference experience. If you feel like you've just been bored at a conference for a while, go to the psychedelic conference. You will not be bored. You know, you'll see a couple wizards in the lobby, and it'll just be like, okay, this is interesting. But go ahead, Bobby. I
Amazing.
interrupted you.
actually, I think that the way you presented it was perfect because
Oh, cool.
yeah, I the conversations I've had with people have been interesting over the past few years, and it's interesting to see how really hardcore 12-step people are so um, adamantly no. And I feel like that's what got me into recovery was that I couldn't keep saying no and never. So I think being open minded and just like you're saying, of course, I love this concept, and I love the fact that you're opening up your mind too, because I know that people have been going to different conferences this past year and been just like you, like kind of like they're not sure how the room's going to take it.
Okay.
So I just love the way you presented it with that on that aspect because we're saving lives. So thank
Yeah, I mean, I'm sure all of you were around. Um, I got um, the first time I went to a meeting was in 1994, and I didn't get sober in 94, but I went to a meeting in 94, and um, I was in a lot of room, a lot of. I wasn't obviously a professional at the time. I don't remember too much about it, but I remember um, how much they would negate people that were on antidepressants as being sober. And, you know, they were in the minority back in 1984, and they're seen now as in the aged minority. Um, and, I hope that if we've got some, like we had some valid research back in the mid 80s that didn't really start to turn itself into acceptance in AA till the late 90s, early 2000s. I hope we're quicker. I hope we've learned from that experience that just because we classified as something as a no beforehand doesn't mean that we wouldn't classify it as a no in some ways with new information. Because what we're not talking about is the value of taking psychedelics at a Phish concert. Um, we're talking about the valid of taking psychedelics in a very research prescribed way in conjunction with therapy, which is not the same as going to a Phish concert.
Yeah, I have a question, Ryan. Thank you for that. I just heard words like um, ego and plasticity, and I know I've been in recovery for 15 years, so I'm thinking about how valuable that was for me to have some kind of something that readjusted my level of ego and also an environment where there was some plasticity that helped me to change my mind. But I have this my idea is about narcissistic personality disorder. And if something like because there's ego involved and because there's lack of insight into oneself, I don't know if this is outside the range of what you would even speak about, but what do you think about like certain disorders and like talk therapy with psychedelics? Is that something that has been talked about, researched?
I mean, I would be worried about personality disorders. To me, there's an element of delusionality around around personality disorders. The origin's different than a cognitively based psychotic disorder, but the psychology is the same. A um, narcissistic person specifically believes that he should only associate himself with special people and elevated people. And that's not too different from the psychotic person thinking that he's associated with aliens. So I would be fearful that using it with a a personality disordered patient might have the same negative impacts as a psychotic diagnosed patient for that reason.
Mm-hmm.
Like I say, no data on that. I think it's worth some study, but I sure as hell wouldn't want to be in that study. So I really, I don't see it probably going that direction. I think that, I think it'll stay around the anxiety disorder, PTSD, depression for a long time. But I do think
Mm-hmm.
that the next movement it'll be into is specifically in the treatment of addicts. Specifically because that's where a lot of the Spring Hill, Maryland research was headed in the 70s. And there's interviews from people in black and white back in the late 60s, early 70s that are reporting a remission of craving and symptoms after LSD and psilocybin treatment. It's a small sample size. It's just 3 or 4 interviews that they have taped from those studies. But, I think that the potential, like again, saying no benefits about it, but the potential benefit based on that research that was done in the late 60s, early 70s is probably, the next field will be directly in people without maybe even a comorbid diagnosis, just a substance abuse diagnosis. I think we're a ways
Mm-hmm.
out on that. I mean, probably, 5 to 10 years out on that. We're not really a ways out on its impact on depression and PTSD. We're pretty much there. And like I said, barring I don't know, a pandemic or a financial meltdown, which all could happen, um, it'll probably get
Yeah.
approved in 2024, and there'll be physicians that are prescribing this in conjunction with therapy.
Mm-hmm.
And of course, I mean, if you work in treatment, like every third call is going to be, do you guys do this once that becomes legal?
Right.
Um,
Mm-hmm.
and so I think, you got to deal with it somehow at this point. The movement, whether you agree with it or whether you don't, is too big culturally at this point to stick your head in the sand about it for sure.
Yeah.
Any other questions?
Ryan, can you speak a little bit to like the differences between like MDMA versus psilocybin versus LSD?
I can't speak to them again from a validated research perspective because we're just trying to validate it as an existing substance. So we're still years away from the comparison contrast types of studies between it. I can speak to it based on, anecdotal reports and people that have used this for various reasons in other communities or in other cultures and things like that. And that is this. I think MDMA, and I've spoken to actually Rick Dobbins on this, who's the head of MAPS. I had an opportunity to have a discussion with him, which was fortunate. And my first question is, why did you go to MDMA versus psilocybin or LSD or something like that? I mean, like, let me back up. The ketamine is an easy legalized one because it was already legal. I don't think that after MDMA and psilocybin get legalized, I think you'll see the ketamine push that you see in America drop way down because ketamine isn't actually technically a psychedelic; it's a dissociant. It has psychedelic properties at high doses, but I just don't think it's as effective as those other medications, and so I think you'll see it reduced after MDMA becomes effective. So I asked Rick, I said, why did you go for MDMA approval with the FDA versus uh, psilocybin? And he said, really clearly that MDMA gives someone the best opportunity to be the most conscious and the most verbal during even the impact of the drug. And so it lends itself the best specifically to active therapy going on while you're under the influence of the medication. So it allows there's a couple of, if you watch the Netflix special, there's a couple taped therapy sessions of people on MDA where you can really see how the person is. They just look like they're your most open client, and not open in a weird way, like open emotionally in a way that's pretty real. You'd think, okay, this is just a person that was really ready for care, but it's their like second or third session. So I think that's why they went with the MDMA first, is because it allows it lends itself most easily to the assisted part of psychedelic assisted therapy. I think the next one will be psilocybin, because I think that also would be kind of next in line for access. It also, psilocybin experience is generally, between 4 and 5 hours long. So it would lend itself to something that could be done in office, under medical care. All of our sessions being done with ketamine care have been done offsite in our psychiatrist's office, completely medically supervised the whole time, with a therapist on site and the nurse on site with the person the whole time. I think LSD would probably be the third one on the list, mainly because of the research done on LSD back in the Spring Hill experiments in the late 70s, late 60s, early 70s. I think LSD will have some problems, though, because of the length of time that people are impacted by LSD is generally, 9-10 hours, which doesn't lend itself to a business day, so as well as some of the other stuff that other things do. So I think that the two main things that'll be out, in pretty quick orders, for obviously for sure the MDMA, since that's on the 1 yard line as it is, but I think psilocybin, because of its chemical properties and duration, it has a lot of usage right now. There's of course, drug companies right now are trying to patent synthetic psilocybin, and prevent people from getting it inexpensively. So that will be another part of the social and ethical debate, is the fact that people are taking natural chemicals and patenting them and requiring you to pay them to have what they could have for free. But that's obviously an issue as old as time.
Capitalism. Yeah.
Yeah, hashtag capitalism.
Yes. Thanks. Yeah. Thanks, Ryan, for breaking that down.
Yeah.
I need to get off now, so I didn't want you to think that I was blowing you off. This has been fabulous. Thank you so much, Ryan, but
Thanks,
I do
Joyce.
need to get
Take
off
care.
now. Okay, so you too. Bye-bye.
Bye, Joyce.
Any other questions people have had? Thoughts, comments in your own practice, maybe your own experience? It's okay. It's just we're in the
Yeah, so I'll
tree of
jump in here.
trust.
Thank you for that great presentation. That was really interesting. I appreciate that. So I am early in recovery, and I just did last week my first ketamine assisted therapy session.
Okay.
And so I've got the program I'm doing that with. I've got two more scheduled next week, and then a couple weeks after that.
So you're doing it with a therapist
Yes, with a therapist in a center that focuses on that practice, and you work as you probably do in your practice. You work with a therapist quite a few sessions leading up to the ketamine treatment, and then they and a nurse are there with you through the treatment. Then I've been doing the follow-on sessions to my first treatment.
Good for you that you're doing the right protocol. That's awesome.
Yeah. So, but and for me, I've been in and out of recovery for years. I've had sort of intractable anxiety that SSRIs didn't really help much with. So I've seen some real benefits from my first session, and I'm hopeful that continues. I will say, the ketamine, the dissociative experience is just, it's hard really to describe with words, but it does really have that, from my at least my experience, it really does have that sort of ego separation that you were talking a little bit about. I mean, you go to this place under ketamine where reality is completely different, and your normal ego mind is just kind of way off in the distance. And so I found it very interesting that way, and hopefully beneficial. The other thing I would say about it is, and this is someone who's, struggled with alcohol use for years, it wasn't the type of experience, at least for me, where I came out of it thinking, oh, I want to do that again, or there wasn't any kind of
Yeah.
like drug craving. It just wasn't that experience. It didn't really have a high to it. It was just like this weird alternative exploration journey kind of experience. But I hope that other people have that same experience, that it's not like doesn't create, new craving or, drug seeking behavior. Because for me, even as someone who has been, high seeking for lots of their adult life, it didn't, at least in the first session, seem to prompt any of that kind of reaction.
Thanks, Noel. I really appreciate your courage and sharing that with us. I think that, Noel's experience is I appreciated the way he described the actual impact of it. I failed to do that. I could have got that better for my clients, but when I've talked to them about it, I can tell you for what it's worth, and I appreciate you telling me for what it's worth, a very similar description. Just similar in the fact that they didn't want to rush out and use opiates or get drunk, and a very similar description to like, it wasn't this euphoria. It was just like this opportunity to see myself separate from my ego. And, that's what we've been trying to get people to do with talk therapy for decades. That's what CBT is.
Right.
So to have an extra tool in that might be able to help people less able to use more traditional means of treatment just seems to be a potential advantage. And I'm glad you're experiencing that. I'm happy for you.
Yeah. Thank you so much.
Anything else? Anybody else? All right. Well, that's all I got. That's all she wrote, folks.
Thank you.
Thank you. And thank you, Noel, for sharing. I just want to say thank you for your courage in sharing that.
Yeah,
And
thank you. I'm glad to be a part of this tonight.
yeah, really glad you're here. And Ryan, thank you so much.
You bet. I was happy to be a part of it. Thanks for letting me in a small way start to talk about this. I'm going to try and talk about it more, and not that I'm trying to convince anyone, but I do think we have to think about it, and I want to give people some opportunity to start thinking about it.
Yeah, thank you. I will. The only other thing I'll add is I did tell my old AA sponsor that I'd done this, and he was somewhat flabbergasted, really very negative about the whole thing.
Mhm.
So there's
Well,
a lot
but
of taboo out there.
that's not going to change unless you talk to him about it, and
Yeah,
the next person
exactly.
talks to him about it. So
Right.
good for you for being at the forefront of the trail where not as many people have to experience shame for trying to save their own lives.
Yeah, thanks for. Yeah, I'm trying every tool I can get.
Good for you.